This is a very poignant topic, and glad to have Dr. Shih here to speak with us. Dr. Shih is coming to us representing the United Hospital Fund, where he's the president. And this organization was established to build a more effective and health and care system for the New Yorkers. He has an educational background with starting off at Amherst College, where he received his BA in economics, his medical degree from NYU School of Medicine, and his MPH from Columbia School of Public Health. He's held several leadership positions, including the Executive Vice President of the New York Academy of Medicine. He has served as the Executive Vice President for Programs at the Commonwealth Fund and Chief Quality Officer at IPRO. I think more importantly, he began his career taking care of patients from immigrant and refugee backgrounds at a community health center in Oakland, California, which helped to start his springboard his interest in health policy, health equity, and the social determinants of health. And with that, I want to bring up Dr. Shih to the podium. Thank you, sir.
Thank you so much. Thank you for the introduction. First, it's an absolute pleasure and honor for me to be here. I'm both thankful and humbled by the invitation, especially looking at prior speakers of this leadership forum. I was first introduced to Dr. Reed about 12 years ago, and I am a big fan of you and the fellowship program in minority health policy. I've been continuously impressed by both the caliber of the fellows, which was reinforced when I met with them last night and this morning, as well as the caliber of the program under Dr. Reed's leadership. I firmly believe in the value of fellowship programs like this that invest in human capital to achieve long-term goals. So as you know, and I suspect that's why you're here, I'm here to talk about the role of the healthcare delivery system in addressing the social determinants of health. This is a topic that is near and dear to me as it relates back, as Alden mentioned, to my earliest clinical experience. My first clinical job was serving immigrant and refugee families at a community-based mental health center in Oakland, California. And I think all of us who go into health professions go into it because we want to help people. But it was clear to me at that time that despite the best clinical care I can give to those patients, I wasn't going to make any long-term impact on their health or well-being, because those were much more related to their other conditions, their poverty, their social isolation, their cultural isolation, et cetera. But at that time, this was about 20 years ago, there were very little discussions about what the healthcare system can do to address these social determinants of health. Luckily, today the conversation is changing so that we can have a meaningful conversation today about the role of the healthcare system in addressing the social determinants of health. Before we get there, I'll do some level setting. So we'll go over the definition of the social determinants. We'll review their impact on health outcomes. And probably most importantly, we'll discuss, why is healthcare starting to get increased interest in the social determinants. We'll move on to discuss the various roles that the healthcare delivery system can play in addressing the social determinants, both at an individual patient level, but also at a community level, but then focus back on the interaction between the delivery system and community-based organizations. And then I'll end with describing some of the work that my organization, the United Hospital Fund, is doing in this area. I do want to acknowledge the obvious that this is a very broad topic and we're only going to scratch the surface, right? It's not like I can teach you cardiology in one session. The social determinants is much broader than that. So I will likely raise many more questions than I'll answer, but that's okay because we need a lot more folks working in this area, and hopefully I can interest you in it. So let me get to my slides. All right, first, again, level setting. What do we mean by the social determinants of health? I think if you look at the academic literature, they'll often reference this definition from the World Health Organization. The social determinants of health are the conditions in which people are born, grow, work, live, and age, and the wider set of forces and systems shaping the conditions of daily life. It's a mouthful. I think RWJ, with their push towards the culture of health, has really simplified the concept to good health begins in the places where we live, learn, work, and play. I think both are fine definitions, but for most people, I think they're too conceptual or too abstract. And so translating these concepts into something more concrete is where I think the CDC has been very helpful. So they start with a similar concept, but then organize the social determinants into these 5 determinant areas: neighborhood and built environment, health and healthcare, not clinical care, but it's really access to health and healthcare, social and community context, education, and economic stability. And then within these 5 broad buckets, the CDC identifies specific factors associated with health outcomes. And the effect of some of these factors are fairly profound. And as you might imagine, it is extremely difficult to attribute the effect to any single one of these factors, but people have tried. You're probably familiar with Sandro Galea, who's the dean of the Boston University School of Public Health. So he wrote a paper a number of years ago estimating the impact of the social determinants, each of these factors, on health outcomes. And he estimated, based on the year 2000 population, that low poverty or individual poverty was accounted for about 133,000 deaths. Low social support, 162,000, which is comparable to lung cancer. Low education, 245,000, which is comparable to deaths by AMI. But more broadly speaking, people often ask, what is the overall impact of the social determinants of health, and how important are they relative to the other determinants? And there's a bit of confusion in trying to pinpoint the contribution. People often point to this chart on the left side of the slide from the county health rankings. Have folks seen this before? Yeah? Well, it's almost always misinterpreted. So people look at this chart and they say, well, this says the social and economic factors is 40%, or they might say social economic factors and physical environment, that's 40 plus 10. So 50% is attributed to the social determinants of health. But that's not what they're trying to do. This is simply a weighting system for their county health rankings, and they're estimates, but it's estimates based on only modifiable determinants. So they're missing one huge piece of the pie in terms of determinants of health here. They're missing genetics, right? So you shouldn't use this chart for attribution of social determinants. The work on the right hand of the slide is much more conducive to that. The upper right is work by Steve Schroeder. The bottom right is work by Alvin Tarlov. But as you can see, there are wide differences in their estimates. So in the Schroeder slide, he has 20% due to social and environmental factors. In the Tarlov slide, you see social characteristics and total ecology, which we can interpret as environment, is greater than 50%. So there's wide differences in this kind of estimate of the impact of the social determinants. But they're both consistent in that when you add the social and environmental factors in both graphs, and in all of them actually, they're greater than the slice of the pie that is healthcare. However, that still underestimates the impact of the social determinants of health, because there's one other slice of the pie here that's greatly affected by the social determinants, and that's health behaviors, right? So a very simple example is cigarette smoking has a big impact on health outcomes. Well, we know cigarette smoking is closely related to education and income levels. And so this is made clear in this next chart. So 2 years ago, I was on the Institute of Medicine committee that was charged with looking at social risk factors in the context of risk adjustment, potential risk adjustment for value-based payment in Medicare programs. And we started by developing this framework of how these social risk factors would impact health outcomes. And I refer to this framework because here we make it clear that social risk factors can have both a direct impact on health outcomes, but also an indirect impact mediated through things like access, behavior, and health literacy. So again, social impact, the social determinants of health have a large impact on health, and most likely larger than clinical care. We don't know exactly how large, but the pathways are multiple and complex. But ultimately, I believe it's not important to know the percent contribution, but rather to understand in the United States its variations in the social determinants of health that are the primary drivers of health disparities in the U.S. And so the evidence is starkest when you're looking at measures of life expectancy. So this is a map of New York City, and I used to work here in East Harlem, which is the red one right above where we're pointing. And 7 blocks to the south of me, which is the tan one, is a neighborhood called the Upper East Side. And straddling the two neighborhoods is a large academic medical center, the Mount Sinai Health System. This scale of the difference in life expectancy of 9 years is not due to differences in the quality of medical care, because the same system is serving both neighborhoods, or genetics. I'm not saying that those had no impact. They might have had some impact. But the scale of this difference is primarily due to the social determinants of health. And that's what's important to understand. So what I reviewed is obviously not new information. I think the public health community has known it for decades. And so the question is, why are we in healthcare just starting to pay attention to these determinants? There's so much interest right now from policymakers to think tanks to healthcare foundations to providers. It's like every organization is putting out something related to the social determinants. The question is, why now, when the public health community has known about this for so long? I would argue that there are 3 major reasons why the healthcare community is interested right now. 2 of them are big picture issues, and one of them is a very pragmatic one. The first big picture issue actually originated here in Boston. It was the triple aim as a framework for health system performance. Who here is not familiar with the triple aim? Oh, there are some people who are not familiar. Well, we'll go over it. So it was developed 10 years ago by Don Berwick, head of the Institute for Healthcare Improvement. And one of the pioneering concepts in this framework that we take for granted right now is that it's not only the health system's responsibility to deliver the best quality of care, which he captured in this experience of care in the lower left, but also for the health system, it's a responsibility for them to deliver the best population health outcomes. And once you start moving the conversation away from individual quality to health outcomes, well, you have to start thinking beyond clinical care, because so much of health outcomes is driven outside of clinical care. So that's the first big issue. The second big picture reason is the broad value equation. So no matter how you measure it, the United States spends by far the most on healthcare compared to any other country. So you can see that in the graph on the upper left. This is healthcare spending as a percentage of GDP, but you can measure it by per capita or any other measure. We are an outlier. We are that brownish line compared to all the industrialized countries. Yet, on almost all measures of health outcomes, and this one is just life expectancy at birth, we are mediocre at best. On this measure, we're ranked 26 out of 35 OECD countries for life expectancy. If you look at infant mortality, it's even worse. We're 29 out of 35. So you have high cost, you have mediocre outcomes. Clearly, an interpretation is that we're not getting a lot of value out of our healthcare spending. But this actually makes sense, because what I just said is that the spending is healthcare spend, right? Yet outcomes are due to something much more than just healthcare. And so in that context, we don't look like an outlier as much anymore. And the clearest example of this is if you look at Betsy Bradley's work. She did this while she was still at Yale. So she looked at not only healthcare spending, and if you look at healthcare spending, this is the lower left-hand graph. Healthcare spending is the white bars, percentage of GDP. And again, if you look at just that, the U.S. is an outlier, on average 50% more than any other countries. But she also looked at spending on social services, and that's represented in the blue bars here. So while the U.S. is an outlier on healthcare spending, we actually spend less, much less than other countries on social services, which are the other drivers of health. So when you combine health and social spending, we're no longer an outlier on total spend. What we are an outlier on is the proportion of funds that we spend on healthcare versus social services. And in order to get more value for your dollars or better health outcomes, you need to change the proportion more on social service spending. People often criticize this because this was comparisons across countries. So she repeated this within the United States on a state-to-state basis, and she found the same relationship. So those states with the higher ratios of social service spending compared to health spending had overall better health outcomes. So again, the second big picture reason that healthcare is interested in the social determinants of health is this broader search for value. But the third reason, and the most pragmatic one, is as well as what I think is the most powerful driver right now for healthcare interest, is the transition towards value-based payment. Clearly, as payments migrate away from fee-for-service models to models that hold providers accountable for both health and cost outcomes, behaviors change. You start by reducing waste, and then promoting value-enhancing activities like primary care and care coordination. But eventually, if you're responsible for health outcomes, and clinical care is a minor component of health outcomes, then in order to succeed under value-based payment, you're going to have to start thinking outside of the clinical delivery system. In New York State, our Medicaid program is even more explicit. We're operating on a massive Medicaid 1115 waiver program right now, $8 billion. It's called DSRIP. And the program is intended to drive payment and delivery system reform. And as part of that, there is a value-based payment roadmap. And in that language, they actually explicitly said to participate in more advanced forms of value-based payment, the value-based payment contractors are required to implement at least one intervention aimed at the social determinants of health. I spend a lot of time talking to health system CEOs, and from my personal interactions with them, I think the interest in the social determinants is real. It's encouraging to try to see the enthusiasm in figuring out how to address the social determinants. This is a real shift. Even just a few years ago, the conversation was completely different. It was related but different. And what I mean was we would talk about the social determinants, but their concern was, well, I serve a disadvantaged patient population. How is my quality measures or payment going to be adjusted so I'm made whole because of that? That's a very different conversation from, I serve a disadvantaged population. How do I address their needs so I can improve their care? And that's where I think the conversation is going right now, for now anyway. So, healthcare providers are interested in addressing the social determinants. What are they supposed to do? I tend to think of healthcare delivery system roles in two very broad buckets. The first is individual patient interventions, and much of the discussion in healthcare delivery system has been focused on this. And the reason I think it's been focused on this, because it's a very natural extension of caring for the patient, right? It's a big stretch in terms of topic, going from a heart problem to a housing problem. But the general model is the same. You diagnose the problem, you help address it. Doing so is very complicated, both the diagnosis and the solution, but you get the general idea. it fits our general model of taking care of individual patients. And the examples that you see are the same examples everywhere, providing supportive housing or meal programs or home remediation for asthma. And I'll return to this later because this is the bulk of where our organization is working right now. But the second role of the healthcare delivery system is in many ways much more radical. And that's focusing on communities or community-wide interventions. So if you're not the only provider in town, and in New York City, we have 5 major academic medical health centers which compete for every single block in New York City. So nobody owns any geographic neighborhood in New York City. This is radical because if you're going to implement a community-wide intervention, it means that you're helping people who aren't your own patients. And that's very difficult for a health system to do. And it can go from things that are explicitly health-related, like farmers markets or playgrounds for exercise, to interventions that improve the overall economic vitality of the community, but are not explicitly health-related, but drive health. So a term that many people use now is hospitals embracing their roles as anchor institutions. Are folks familiar with the term anchor institutions? I hear a couple of mixed responses. So anchor institutions are large enterprises that are rooted in their community and that way have an outsized impact on the local economy. So decades ago, who were the anchor institutions? They were the for-profit companies, the large manufacturing companies, the big 3 automakers, the Kodak, the IBM. These were the companies that made company towns. And they invested in their communities, and by investing in the communities, they improved the economic conditions of their communities, and by so doing, improved the health of their communities. But as we transition to a global economy, these entities no longer are rooted in their community, right? So their capital flows to where they can make the greatest return on investment. So you can no longer rely on these for-profit companies as anchor institutions. The remaining anchor institutions today are healthcare and educational institutions, or what we call meds and eds. Healthcare systems that embrace their roles as anchor institutions really leverage their assets, and I mean beyond their community benefit spending, and community benefit spending is required of hospitals to maintain their nonprofit status, but also their hiring and purchasing practices to drive the local economy. And again, if you drive the local economy, you improve the overall health of a community. This aligns with their commitment to improve health and is consistent with their responsibilities as a nonprofit institution. There's a national collaborative called the Healthcare Anchor Network. It was started about 1.5 years ago with about 40 health systems, including a few here in Boston. And it will be exciting to see how this movement progresses. Let's put aside the anchor institution discussion for now, because that's really more of a future state and focus on solutions. Again, the easier paradigm is focusing on solutions for individual patients, and this is where we see most of the action right now, especially given the pressures of value-based payment. And remember, we're talking about interventions that are outside of clinical care, which means more often than not, the healthcare system has to partner with a human services organization, which I'm going to call community-based organization, or CBO for short. And in order for this to happen effectively, we're talking about creating true partnerships, not simply having a directory of agencies to refer to. And an analogy that I often use is coordination between primary care and specialty care. To be effective, it's not just about referring your patient to a specialist, right? You want to have the specialist treat the patient, but also close the feedback loop with you so that you can incorporate whatever consultation that they have into your treatment plan for the patient. So if you stay with that analogy, it took us decades to figure out effective coordination between primary care and specialty care. And one can argue that we still don't do it all that great. And certainly, we don't know how to coordinate well between hospital and other settings like nursing home. And that's within the same healthcare sector. So when we're talking about coordination and collaboration with a completely different sector, like the human services sector, this is not going to happen overnight, even if the financial incentives are aligned under value-based payment. So I've been spending some time trying to bridge the two sectors, healthcare and the social service sector, and served on a commission that examined partnerships, particularly in the context of value-based payment. And some of the challenges that we identified are listed here. Culture and language, and I don't mean race and ethnicity. I mean the culture of our two sectors is completely different. Just think about all the acronyms that we use in healthcare. Well, they use a completely different set in the social service sector. It's not like that they just don't understand us. They just talk a completely different language. Technology and other infrastructure. We in healthcare, some of these large systems have invested well over $1 billion in putting in electronic health record systems. In the social service sector, you're lucky if you see a collection of Excel spreadsheets in general. And so this difference between technology and other infrastructure, including kind of legal and compliance staff, is huge. There's an issue with social service sector capacity. You actually need extra staff and capacity to devote to establishing these partnerships. I don't know what it's like here in Boston, but in New York City, 20% of social service agencies are in the red. They're underwater. And over half of them are what we call in financial distress, meaning less than 3 months in financial reserves. So this is not a sector that is primed for any additional work to be heaped upon them. There's the issue of financial support, and again, supposedly that should be addressed through value-based payment, but I'm going to come back to that later. Regulatory barriers, we have our own HIPAA issues. The social service sector has their own issues, especially since many of them are also funded by government contracts. There's the fragmentation of the social service sector. They're even more fragmented than healthcare was 2 or 3 decades ago. And then there's the trust issue. It's a big issue for CBOs, especially given this power dynamic between organizations. And in New York State, it's even worse because, as I mentioned, we're under a big Medicaid waiver. A lot of that $8 billion was supposed to create integrated delivery systems where funds flowed to the CBOs, and almost none of that money materialized. And so CBOs are understandably a little reticent about partnering with the healthcare organizations. They also worry about their work being medicalized, and they worry that if the healthcare systems start to understand their work, they will start doing it themselves and cut out the social service sector altogether. Now, I know that there are many commercial companies, including a few here in Boston, that are trying to bridge the healthcare and social service divide. And initially, many of them were just focused purely on the technology and referral aspects, kind of building up lists of agencies and figuring out how to coordinate using technology. But there's now increasing recognition that those are just two barriers, that the issue of building true partnerships is much more complex than that. I'm going to switch gears now and talk a little bit about where I work. United Hospital Fund, independent nonprofit. Our mission is to build a more effective healthcare system for every New Yorker. We were founded in 1879, so we've been around for a while. We are neither hospital-focused nor a foundation, so the name is a bit of a misnomer. So our core activities are independent research and policy analysis. We do a lot of convening of diverse stakeholders around critical issues in healthcare, and we develop and support innovative programs that improve patient care. So much like a think tank with a little bit of program and implementation type activities. We currently have 3 focus areas. The first is improving coverage and access. In New York, like Massachusetts, was very aggressive in implementing Obamacare, but we still have about 1.2 million that are uninsured in New York. improving the quality and efficiency of care, and then the newest area, which is directly relevant to today's discussion, is clinical community partnerships. So I launched this area earlier this year formally, and the focus is precisely on what we've been discussing, which is this intersection of the healthcare delivery system and the community to improve health and to address the social determinants of health. We launched this area because of all the reasons I said, the interest in this, but also because this is a critical part of improving the healthcare system for disadvantaged populations, and this is a personal priority of mine and one of the organization. We have a growing portfolio of projects in this area, which I'll briefly review, ranging from testing measurement strategies to building collaboratives and partnerships between the delivery system and CBOs, starting with pediatric clinics and then later with adult primary care, and then working at the policy level on building cross-sectoral collaboration. So the first project, we recently completed a learning collaborative testing PROMs in primary care. Are people familiar with the term patient-reported outcome measures, PROMs? It's relatively new. So as you all know, typically healthcare outcomes are assessed in terms of what happens to a patient as observed or measured by a clinician, right? A complication or blood glucose control, et cetera. So PROMs are, by definition, self-assessed or self-reported by a patient. So they've been mostly used in research to date, very limited use in clinical practice, except for specialties like orthopedics and rehab, where they rely a lot on patient-reported functionality in terms of to address their outcomes. So we launched this aiming to, again, test PROMs in primary care, and the most interesting part of this project was 2 of the participating health systems chose PROMs that were not based on clinical outcomes at all. Actually, they chose PROMs that were based on social determinants of health-related health stressors, things related to housing, economics, food security, and domestic violence. We're in the process of writing this up, but the preliminary findings suggested that first, asking and talking about the social determinants of health affected the primary care encounter in positive ways. So these were issues that were clearly important to the patients, and they were clearly not driven by our clinical and EHR-driven priorities, which I think patients get used to. And I think because of that, it improved trust between the provider and the patient and improved communication. And several of the clinics reported observing increased patient adherence to the overall treatment plan. It also appeared to improve both patient and provider satisfaction. Now, there are very, very few interventions that do all of these things: improve trust, adherence, patient-provider satisfaction. And we're not even talking about addressing the social determinants. This was just testing, bringing them into the primary care encounter. So this was exciting. Obviously, this is just a small sample, but we're in the process of writing this up. Our biggest investment to date in the area of clinical community partnerships has been in our Children's Health Initiative. As you're aware, what happens in the early years of a child's life can have a lifelong impact on health, education, and social outcomes. But much of the negative impact are from things that are outside of traditional healthcare, like poverty and trauma, et cetera. Again, the social determinants. So the question we asked ourselves is, how do we address those? And one lever of opportunity is the pediatrician's office. We chose the pediatrician's office because kids, regardless of socioeconomic status, almost all of them visit a pediatrician's office on a regular basis. And there are very few places like that. The other place that this happens is school, right? School, kids of almost all socioeconomic status go to school, but we're trying to intervene in the first 3 years of life, so this is preschool. So we launched an initiative that focuses on children's primary care as a focal point for addressing the social determinants of health. It's called the Partnerships for Early Childhood Development. We had 11 clinics from across the city that participated in wave one of this initiative. And in order to participate in the collaborative, each of the clinics had to bring a community-based organization partner with them that could address one or more of the social determinants. So the focus of this collaborative was building these partnerships, working on a way to figure out how to effectively screen, how to refer, and then most importantly and complicated is how do you close the feedback loop? How do you find out what happened on the social determinant side and incorporate it into the treatment plan for the patient? Here are findings from phase one across all the clinics. There were over 5,500 families screened for the social determinants issues in the first year. Almost 1,900 of these families were identified as having one or more social need. The most common social needs were related to adult education, childcare, and food insecurity. And then after identification of the need, you can see that there was a steady drop off in terms from referral rates to service use and then feedback. We are now entering the second phase of the project, and we're going to be focused on strengthening the connection to the community services and working on the feedback loop. But some of the specific barriers that we observed are consistent with my earlier slide on general challenges to these partnerships. And some of them are inherent to when you pilot something. So when you pilot something, your EHR isn't going to be set up for that. So there were a lot of workflow inefficiencies from paper tools and EHR workarounds. Sharing information between a clinic and CBO is labor intensive, especially without the help of technology. There was a lot more training than we anticipated needed for the workforce, especially on the clinical care side. Again, you're introducing something new to the workflow that they're not used to doing at all. Trust and engagement with the families was a huge issue. These were mostly clinics that served Medicaid and uninsured patients. Many of the families were immigrant families, and in the current political environment, many families were wary about why are you asking me about these issues that are not clinically focused. We could have predicted that the CBOs needed much greater investment than we offered in terms of developing these partnerships. True partnerships take time, but we had a couple of clinics that were so successful at the clinic level that it spread enterprise-wide, meaning that these are large health systems with 10, 20,000 employees, where they took the success in a pediatric clinic, scaled it to other pediatric clinics, and one even scaled it to adult. And finally, the last project I'm going to talk about is one that we worked on called the first 1,000 days on Medicaid. And just to let you know, that phrase is used quite often, so it means different things in different states. But we were asked by the state to work with stakeholders to craft a plan for how Medicaid can work with other sectors that impact health and education for children ages 0 to 3. This was a multi-stakeholder process, led to a set of recommendations that was included in the governor's 2018 State of the State. And I mention this because it's important to not only work at the provider level, but also at the systems and policy level to connect the different sectors that impact health. And then finally, as I think about how we as an organization proceed along this path, continuing to build out our work on clinical community partnerships, these are some of the issues that I struggle with. The first is, how do you sustain these partnerships? And I call this the promise and pitfalls of value-based payment, right? So value-based payment is driving this, and the notion is, well, if these really impact health outcomes, part of the value-based payment will be used to flow to the CBOs. Well, that only works even theoretically for high utilizer patients, right? Because in only those cases are you going to get a short-term return on investment. But we also know that a lot of the population who are not high utilizers have social needs as well. And if you focus only on value-based payment as a solution for this, then you're going to miss out on that entire segment of the population. That population is not going to provide a short-term ROI in terms of decreased healthcare costs, but there's a good chance that they're going to provide a medium or long-term ROI in terms of healthcare costs or cost savings to other sectors like criminal justice, et cetera. The problem with our healthcare system, obviously, is no one takes that long view because no one owns the patient for that long. The second issue that I struggle with is the evolution of the human services sector. Like I said before, it is a very fragile sector right now. In New York City, 20% insolvent, 60% in financial distress. And it's interesting because when you compare this to healthcare, so for instance, when we want, at least in New York, I don't know how they do this in Boston, when we want our primary care practices to become patient-centered medical home, we invest hundreds of millions of dollars in supporting primary care practices. Or when we want them to adopt EHR, we create a several billion-dollar program to give to the healthcare systems to do that. Well, now we're asking the human services sector to do something very different from them, and no one's offering them any money to do any of this. And so for us to expect that the human services sector is going to simply evolve because that's good for the population is unrealistic. So I worry from a policy level, how do we convince greater investment in this sector? And then finally, I worry that with all this interest in the social determinants of health, again, it's very much focused on what we're comfortable with, which is intervening at the individual patient level. And I think if you intervene at the individual patient level, there's only so much you can do at the community level. And so in order to improve community health as a whole, you need to be focused on community health. And the question that we struggle is, how do we get the health system to have this perspective? So I think I'm going to end there, Alden, if that's okay with you. And